Good evening and welcome to Conversations Live, the Heroin Epidemic Revisited. I'm Patty Satalia. Drug overdoses in Pennsylvania started to spike in 2011, and much of the increase is due to heroin. Experts now say every community in Pennsylvania has a heroin problem. Recent reports place some of the blame on easy access to prescription painkillers, gateway drugs for most users. Tonight, our experts will discuss causes and solutions to this rapidly growing epidemic. They'll also take your questions. Now, let's meet our guests. Senator Gene Yaw has represented the 23rd Senatorial District of Pennsylvania since 2008. He also serves as chairman of the board of directors for the Center for Rural Pennsylvania, which has released multiple reports on heroin's growing presence throughout the Commonwealth. Dr. Philip Moore is an internist and medical toxicologist with associates in medical toxicology. He specializes in poisoning, overdose, and drug interactions and has experience in outpatient and inpatient detox, as well as neutral, partial, and full agonist maintenance therapy for drug addiction. Amanda Cope is the administrative director for Positive Recovery Solutions, which provides controlled medical care and case management services to those suffering from opiate dependence. Thank you all so much for joining us. You can join tonight's conversation. Our toll-free number is 1-800-543-8242, and our email address is connect@wpsu.org. You may also tweet your question or comment to WPSU and use the hashtag WPSU Conversations. I want to begin with you, Senator Yaw. You said if you think there isn't a heroin community in your problem, think again. And in fact, as chairman of the board of directors of the Center for Rural Pennsylvania, you have convened 2 consecutive years hearings, statewide hearings on the problem. Give us an idea of what you learned from those hearings first, and secondly, what the scope of the problem is.
Well, it's really interesting how it got started. The Center for Rural Pennsylvania, first of all, is a joint legislative agency between the House and the Senate. It's bipartisan, bicameral. And the way it really got started is one day one of the other senators approached me on the floor of the Senate and said, can't you use the Center for Rural Pennsylvania to bring to everybody's attention, excuse me, the nature of the problem, the heroin problem in rural Pennsylvania? I mean, that's where we started, rural Pennsylvania. And it sounded like one of those things, okay, it's a good idea, let's look into it, we'll have a hearing maybe in Harrisburg. Well, the more we thought about it, we decided, this in 2014, we had 4 hearings throughout the state, mainly concentrated in the rural areas. I'll give you just a little bit of an example. The first hearing we scheduled for 3 hours in Williamsport. Well, it lasted 5. That kind of was the precursor to say, I think that we may be
You've hit a nerve
here. We hit a nerve. And I give credit to the board of directors for the Center for Rural Pennsylvania. This is a little outside of the way that we usually operate. And they thought, they were the ones that said, we think that it is a big enough problem to go ahead and do this. So we followed up that in 2014, the primary issue, or what we were looking for, is how broad the problem was. What are we looking at here? What is it? In 2015, when we had hearings this summer, we looked into recovery programs, and such as Amanda's. What's gone on out there? I hate to say this, or maybe I should say it, we've talked about it with the board, and we intend to probably look at specific treatment programs and what's successful. But we've issued 2 reports. I think that the Center's 2 reports are probably the most comprehensive work that's been done by the state across the board to really hit at the problem at the ground level.
And, you know, when you look at Pennsylvania as compared with the rest of the nation, Pennsylvania ranks 3rd in heroin abuse and I think 7th in heroin abuse overdose deaths. You know something about this, Amanda. Tell us a little bit about the population you're working with and how Positive Recovery Solutions is interfacing with literally hundreds. There are hundreds of thousands of Pennsylvanians who are in need of treatment, and only 1 in 8 are getting it.
Yeah, so when we found out about Vivitrol, we had a representative of the medication come in and...
Let's back up. What is Vivitrol?
So Vivitrol is a long-acting naloxone. So what it does is it comes in and it attaches to the opiate receptor and essentially locks it down, meaning that when a patient is on Vivitrol, during that 28-day span, while the medication's on board, they cannot successfully abuse alcohol and opiates. It prohibits the release of serotonin, dopamine from the brain from taking that substance in, meaning that you don't get that euphoria. You don't get the pleasure reward system. That's where it works in the brain.
So people are coming to you in Western Pennsylvania who are saying, I need help. Your Positive Recovery Solutions is providing Vivitrol to them. So explain, what population are you serving? What counties are you serving? And I understand that of the 67 counties, 37 counties think they need the sort of mobile clinic that you have.
So we have two physical locations. We are in Allegheny County, in Pittsburgh, and we are in Washington County. And when we added ourselves to the provider locator, meaning if somebody was looking up Vivitrol, you can look and see where they're a provider that can follow you. We added ourselves to that provider locator, and what we realized right away was that people were traveling sometimes 4 hours to come to our facilities to receive their injection. There are not enough providers out there that are willing to either follow this patient population due to the stigma, or there's just not enough education in the medical community about the medication and how to provide it to the patients.
The bottom line, Dr. Moore, is that, as I said earlier, only 1 in 8 people in Pennsylvania who need addiction treatment are getting it. Why is that the case? Many say it's a funding problem.
This is a complicated answer. Physicians are definitely, they don't have training in how to manage this population, and so because of that, they're afraid. They're afraid to manage the population. So one thing we can do is to offer more training to physicians as they all throughout their careers, early on and middle and later. And then also access for patients to treatment facilities or to outpatient. There is not enough providers and facilities for patients to go.
Speaking of training physicians, 80% of those who present with drug addiction, heroin in particular, say that they began with prescription painkillers. So education of our physicians, Senator Yost, certainly is important, and I know that is something that you did address in your hearings.
We did, and we're actually looking into some legislation that would affect the mandatory medical education, not in a way that would expand it, but just say that, for your CME training, it would require a certain amount of time addressed to either pain management or drug addiction. And we've gotten a pretty good response from, we had one of our hearings at the Commonwealth Medical College, and the people there were even willing to, it should be taught in the schools too.
Let me get back to something I was sort of getting to a moment ago, and that is how big this problem is. From what I'm reading, from your report, 52,000 Pennsylvanians are currently in treatment, but there are 760,000 at least, some say even more, who are in need of treatment. So on one hand, we've had a 25% cut in the kind of funding that would provide care to them, and the problem has quadrupled. How do you, as one of our state representatives, feel about that? What can we do about it?
Well, if you would have asked me 2 years ago what I knew about the drug problem, it was not much, and I agree with you. It's something we need to address. Some of the things we didn't, you mentioned only peripherally, there are 7 people a day die in Pennsylvania of a drug overdose, 7 people a day. And, you do the math, that's 2,500 people a year, and the cost that's involved in that, it's astronomical. And this fall, there was a report released by DEA that specifically addressed the problems in Pennsylvania. And I'm not proud of these numbers, but the #1 county, and what it did is it addressed drugs or deaths per 1,000, overdose drug deaths.
Is it Washington County?
100,000. No, it's not. The number one is Northampton County. Number two, surprisingly, but it fits in with what we started to do, is Tioga County.
Really rural areas where you think, who's using heroin in rural areas like this?
Number three is Schuylkill. Number four is Mercer. Number five happens to be my home county, Lycoming. And you'll be happy to know that Center County is number six. So if you look, if you drew this out on a map, it's right down through the center of the state, and even Union County is a part of that too. So this is a very appropriate topic when we say it affects
every county.
Everybody.
Every county. 1 in 4 families is what I'm reading as well. I want to take our first call. We have Rhonda, who is on the line. She's calling us from State College. Rhonda, what's your question, please?
Well, I have a couple, but the first I guess I'd ask is, where is the heroin coming from? And the other thing I'd like to know is, does today's heroin compare in terms of potency? How does it, is it more potent today than it was in previous eras?
Good question. We'll begin with you. Senator Yaw, where is the heroin that's making its way to Pennsylvania coming from? And we'll follow up with you, Dr. Moore.
Primary source overall is Mexico. But the Attorney General's office testified at one of our hearings, and the state's basically divided up for where the drugs come from. I mean, the Pittsburgh area is probably Detroit. Harrisburg is Baltimore. Williamsport, for some reason.
And before that, Mexico, of course.
Yeah, is connected to Philadelphia, and of course on the Scranton, Wilkes-Barre is New York City. But I mean, we know where, the law enforcement knows where it comes from, and the majority of it comes in by motor vehicle truck.
And in terms of potency, Dr. Moore, what's the difference between heroin of yesteryear and heroin today?
That's a great question. It is much more potent. It has increased in potency, and the cost has decreased, and that's what makes it so attractive. Persons often start with prescription, and they may have it for a couple of weeks, maybe a couple of months, and then it's abruptly stopped. And there's
the prescription, they run out of their prescribed medicine from a physician.
And it may just run out, and the physician hasn't educated the patient, like, we need to gradually reduce these doses. So it may just all of a sudden run out, and then all of a sudden the patient feels they have this horrible sickness of, like a viral syndrome. And I've heard it also being described as run over by a train at the same time as having like a severe cold.
So that's what withdrawal from prescription painkillers can be like.
And so the patients will often start buying the pills on the street, and it's very, very expensive to do that. And then they see this very inexpensive drug, heroin, which is potent, and the transition just happens.
60 Minutes put the blame, at least partially, for this heroin epidemic on the pharmaceutical industry, and pointed out that Vicodin was the #1 most prescribed medicine in America from 2009 through 2012. So, do we need to have a different understanding of how to treat pain? And I say that because, most Americans have some degree of back pain, and experts are now saying exercise is going to be more effective than a pain pill.
Well, I think it goes back to education and pain management, and maybe I know the popular thing now is that we're pain-free, and I understand that. Dentists are classic example. Nobody wants to have a toothache. You mentioned a toothache, and no, but I think that pain management is going to be the answer with education, and we may not have to. We may have to put up with a little bit more pain than what we do.
To get a handle on this. We go to Catherine, who is calling us from Altoona. Catherine, what's your question or comment?
Patty, first I'd like to say thank you for having this forum. I'm calling on behalf of the Commonwealth Prevention Alliance, which is the statewide organization for drug and alcohol prevention professionals. And this past year we created a website called pastop.org, which is designed to educate Pennsylvanians about the risks of prescription painkillers and heroin use. On our website, we have information for families, caregivers, and individuals seeking help, and we also have free downloadable materials that answer questions and guide people to the lead agencies in their counties in Pennsylvania to find help. But first of all, we are there to prevent, and a lot of our information does help that aspect of the problem.
All right. Well, thank you for your call. And as Catherine said, that website includes information for resources in every single county. Tell us, Amanda, a little bit about how overwhelmed your services and how available services are for the people who need it, and explain which counties you're serving.
So currently we have, again, the physical location in Allegheny County, the physical location in Washington. We go via mobile unit to Blair County in Altoona, and we go to Indiana County, Armstrong County, and Clarion is also some of the patient population that we service. When we formed this pilot program in July, there were 37 counties that reached out that said, we want access to your services. Unfortunately, the ability to move forward for those counties depends on the budget, so on and so forth. So we've seen a little bit of a delay there, but I think that things are going to start rolling now that I think there's been some leeway made there. But we started out with 4 patients in Blair County, and I have to say we work with the single county authority. So that's where a person who is unfunded or somebody that's looking for treatment, they would be placed into a treatment program, or they would be provided with referrals and resources. We contract with them, and Judy Rosser in Blair County, we started this program with her, and we started with 4 patients. And right now, we go there on a biweekly basis with a mobile unit, and we're probably doing about 30 injections each visit that we're out there. In Indiana and Armstrong today, we had, I think it was 32 patients scheduled today.
So explain how Vivitrol works. It's an injection, and it will keep addicts from using alcohol and drugs. But for how long does that injection work?
The injection we give, it's every 28 days. So we give the injection, and during that 28-day span, they're not able to achieve the high. This medication is meant for these patients to be able to engage in wraparound services. It provides them a safety net so that they can get busy with the work of recovery, because medication alone is not going to solve the problem. So what we do is we pair with behavioral health entities. The behavioral health entities provide the drug and alcohol counseling, which is essential to a successful road to recovery. We provide the medical services. So during this time, it's a safety net for these patients. It's a light at the end of the tunnel for them. If you can give somebody who's suffering from addiction a way out and say, listen, these are the steps you take. This medication, it takes away any cravings to use. You're not craving the drug. You're not craving alcohol. There's no withdrawal symptoms, because it forms the complete abstinence model, meaning when you're on Vivitrol, you don't have to continue to crave substances, and it's non-addictive.
And you're speaking to some extent from experience, because you're 9 years yourself in recovery from alcohol addiction.
Yes. So I'm an alcoholic. May 6, 2006 is my sobriety date. I was not a Vivitrol patient, but I'm a product of long-term treatment. I did the 28-day rehab and then followed that up with a voluntary admission into 6 months of a halfway house. And it truly saved my life, because when you are struggling with addiction, you don't know where to turn. You don't know what to do. And a lot of these patients, they need a stepping stone. They need somebody to say, okay, take this step, and to create some structure, and to form a healthy support system, and change your behavior patterns and healthy coping mechanisms.
I want to go to a phone call in just a moment, but Dr. Moore, how important is individualized or tailored treatment? Amanda was talking a little bit about what her service does and the service that she herself received. Is it important that addicts receive, someone suffering from addiction, get a specifically tailored program?
Yes, it really is critically important but that process is about hearing their story, where they've been, where they've come from, and then from that history, then pointing them in the right direction of where to go with therapy next. Sometimes it's better to not repeat history and keep going with the same therapy that hasn't worked in the past, and to shift it into a new direction and try something new. So that's the type of unique approach that a patient really needs.
Okay, I want to be back. Oh, go ahead, Senator.
What I'd like to say is that, and this fits in with everything that Amanda and Dr. Moore said, this addiction that we found out is a disease. It's a lifelong problem. It is not going to be fixed with a 30-day period of treatment. It's not going to be fixed with a 6-month period of treatment. And what we learned in all of our hearings is what we've commonly referred to as a warm handoff. You go from one part to the next, and it's a community problem.
In other words, the physician is going to introduce you to the counselor that they want you to work with.
We hope, and that's why it's a community problem. It affects everybody. You can't arrest your way out of the problem. You can't use other drugs to get out of the problem. I use this example all the time. If somebody has diabetes, you don't send them away for 30 days and they come back and they're fixed. And that's the nature of the problem. Diabetes is probably, for a lot of people, it becomes a lifelong challenge for them. And the drug addiction is no different.
All right, let's go to our next caller. Eric is calling us from Harrisburg. Go ahead, please, Eric.
Yes, I'm wondering why, Ms. Cope was talking about how they're working down in western Pennsylvania. This question is probably for the senator. Why don't we have this program available to all the counties? I mean, particularly here in central Pennsylvania. I had a friend just 2 weeks ago who overdosed. Isn't there something that can be done in central Pennsylvania? Can the senator do something to make BRS get down there?
Well, I don't know who's paying for the Vivitrol program that Amanda spoke about. One of the comments about the Vivitrol especially is it's very, very expensive. It's somewhere between $800 and $1,000 a shot. So it is significant. There's questions about health care insurance. We've worked on those. We've tried to. I think that there's been more money put into drug and alcohol programs this year. And we now have a Secretary of Drug and Alcohol which just came on board within the last 3 or 4 years, something like that. So I think that it is a problem, no question about it, that we've just started to address.
You know, Eric mentioned having a friend overdose recently, and that brings me to the question of naloxone, which has been saving lives throughout the country. Can you tell us a little bit about who's using it, why there is some reluctance among police departments to have it on hand, and just how readily available it is today?
Well, the Physician General of Pennsylvania has put out a blanket prescription where it can be acquired.
It can be acquired by what, a family member, anyone concerned? Family
members, and very easily. And it's something that she has supported. But naloxone, the Pennsylvania State Police carry it in all of their patrol cars.
And we should say it's an antidote. If you are suffering from respiratory problems from an overdose, this can quickly turn you around.
There's a simple question, I guess, that has to be answered, and that is out there that in order to treat somebody or to save them from a drug addiction, they have to be alive. Now, we have to make that decision, and some of the departments or some counties, Delaware County, the district attorney in Delaware County just took this on as a major project and required that all of the police departments in Delaware County carry naloxone. They've had, I don't know, somewhere 100 saves since they started last November.
Some people are afraid that it's going to create dangerous behavior, high-risk behavior. How do you respond to that?
Well, here's how I respond to that. If you're a police officer, you're trained to handle dangerous behavior. And the physician general said most likely when people are treated, and Dr. Moore would be better off to describe this, but people wake up slowly, and a lot of times they're just confused. They don't know where they are.
But I mean, it'll encourage more people, hey, there's an antidote, I'm going to try this heroin because now someone can save me.
When we did the hearing in August, and the district attorney from Delaware County, I asked him that question. Are you've saved at that point 90-some people. How many repeat customers have you had? At that point, they had 4. Now, 4 out of 90 is a pretty good. I don't know what happened to the other ones. Maybe they got treatment. Maybe they were scared to death, or something else happened to them. But I think it's worthwhile that, and just the cost that's involved in this, from health care, and not only the addiction, but loss of jobs and everything else.
Dr. Moore, you had something to add?
Yes, the naloxone injections, there's a generic and there's also a brand name.
Narcan.
Narcan's the brand name, but there's a company that makes an injection kit that gives you instructions about what to do, what's the next step is. And I've heard that on the website for fire departments, police departments, you can apply and get funding from the company to get a shipment of them to get you going with the injections.
They would be preferable. The auto injectors, they actually talk to you. We've seen them
and tell you step by step what to do.
Tell you step by step. The police departments, most of them use the nasal spray. It's less expensive.
The other thing that I've wondered about those kits is if we need to be prescribing them with. We know certain patients above certain milligram strengths of their prescription pills are high risk for overdose. Should we be handing out those prescriptions with a prescription for naloxone or the auto injector, because we know that's such a high risk population?
You had something to add earlier, Amanda.
Yeah, it would be circling back a little bit. I just wanted to point out that the medication is covered by all insurances, including Medicare, Medicaid, and that we are an insurance-based company. So anybody that has Medicaid, has state insurance, has a commercial insurance, would be somebody that we would be able to follow. We don't charge our patients cash to come and see us. We do everything through the insurance company.
Have you been doing this long enough to know what your success rate is? Because as I said earlier to Dr. Moore, it's not uncommon for someone suffering with addiction to be in treatment 8, 9, 10 times before they're really in recovery.
So I did a TV program back in October, and we had one of our patients on with us who is a mobile unit patient, and he has been in and out of institutions for 20 plus years, and this is the first time in over 20 years that he has celebrated long-term recovery. He has been with us for going on 7 months now, and he spoke on the TV program with me that, hey, people want to say this isn't a miracle drug, but I'm here to tell you that it is. And so we have patients that if you give them a way out, the reason why they continue and they perpetuate the behavior and they do the same thing is they don't want to be sick. This is a way out. They don't have to live that way anymore.
If you're just joining us, I'm Patty Satalia, and this is Conversations Live, the Heroin Epidemic Revisited on WPSU. Our guests tonight are Senator Gene Yaw, the state senator from Pennsylvania's 23rd District, Dr. Philip Moore, a medical toxicologist specializing in treating drug addiction, and Amanda Cope, a registered nurse and the administrative director of Positive Recovery Solutions. Our telephone number is 1-800-543-8242, and our panel is ready to take your phone calls. If you'd prefer to email us, our address is connect@wpsu.org. And we go to our phone now. Timberly from Altoona is on the line. Go ahead, please, Timberly.
Yes, my question is you say heroin and addiction and stuff can start with prescription medications. Personally, it affects my life. I just lost my mother due to a prescription problem. And what I would like to know is, why isn't there a bill or something placed to where when you're going to the doctor, everything related with your Social Security number, why is it so easy for people that are for addicts to go from doctor to doctor and keep getting these medications that they overdose on? And then eventually, if they don't get the Narcan, they eventually die.
That's an excellent question, and the reality is you talked about 7 people a day die from a heroin overdose. 16,000 people a year die from prescription drug overdoses. So how would you answer her question, Dr. Moore?
Several states in the country have programs for prescription drug monitoring, which allows you to see where a patient has been filling their prescriptions. Pennsylvania has, my understanding, has been approved for this program, but it hasn't been fully developed yet. That's really the key to being able to detect patients that are doctor shopping. Now, if the problem with those systems is if you lived on a border of a state, they might not detect someone getting prescriptions in another state and going to the border, going across the border. So we really need to have a national monitoring program.
Senator Yaw.
The legislature passed a prescription drug monitoring program in Pennsylvania about a year ago, and it was a follow-up to our first series of hearings about the necessity of such a program. Unfortunately, it's not been fully funded yet, and my understanding, the last I heard, was that it will take maybe a year to get all of the equipment set up to do that program. But we have one.
The interesting thing is a program like yours, Amanda, Positive Recovery Services, will leave patients with a 7-day prescription, not a 30-day prescription, and yet insurance companies incentivize 30-day prescriptions. That seems to me to be something we need to change.
So one of the things to consider as well is that, unfortunately, we touched on it a little bit earlier, pain is now considered the 5th vital sign. So, and reimbursement is due to patient satisfaction. So there's some inner dynamics there that aren't correct, but it's the reality of our situation. So if you are being reimbursed based on, and this is like at a hospital level or whatnot, but if you're being reimbursed based on whether or not your patient felt that they were appropriately taken care of, and you're a patient that's coming in and claiming, some sort of pain, and they're not being medicated for that, you can see how that kind of flows. There's a lot of different moving pieces to this problem, and I think that we need to come together as Dr. Moore suggested on a national level.
It's interesting, and I said this earlier. A number of studies have proven, though, that exercise can be as effective, if not more effective, in treating pain than pharmaceuticals. Are doctors, do you anticipate a day when doctors are more readily going to be prescribing exercise, Dr. Moore?
I hope so. My patients, I am always encouraging every single one of them to exercise because it's so important for that addiction piece. A lot of them are addicted to opioids, and exercise increases those natural opioids, and so it is imperative to exercise, and one of the keys to breaking that addiction.
And we know that tolerance, the longer you're on a prescription, the higher your tolerance level for it. So you need more to get the same impact in terms of pain relief or high. Look, you look like you were going to add something, but I'm going to go quickly to a phone call. John is calling us from Altoona. John, you're on the air.
Yeah, hi. I was wondering why nobody has ever mentioned the fact that since we invaded Afghanistan, the opium production there has skyrocketed to the point where it's at record levels, and production there is hand in hand with the corrupt government that we support. The other side to that is the money that we invest in these unnecessary wars could be put towards not only medical needs here, but also opportunities in low economic areas, a lot of the Rust Belt areas, for people to have opportunities and to have not only health care, but jobs and futures that they don't currently have. I was wondering what the senator thinks of that.
Yeah, interesting observations. Is there a link between poverty, unemployment, and drug addiction? And
I think that there probably is, but you know, I don't mean to be flippant about it, but you know, what happens in Afghanistan and you know, I don't really have anything to say about it. Of course, if we didn't spend money on other things, we would have more to spend on this particular health problem as with other problems.
Yeah, it was the second part of his comments that I thought were particularly interesting. The opportunity, the poverty and unemployment. You look at places like Williamsport, for example, and as unemployment rose, so did heroin use.
I think that to some extent that's true, but what we found out in our studies is the heroin problem is not specifically related to poor. In fact, the most likely candidate for a drug overdose in Pennsylvania is a white, middle-aged male.
Interesting. Amanda, you had something to add.
I was just going to say, I mean, from our patient population, the days of your addicts being the people that live under the bridge, those are long gone. These are your neighbors. These are your spouses, your teachers, your doctors, your mailman. It affects and it touches every aspect of our life. Looking at the patients that I see that walk through our doors, there are people that are well below the poverty, but there are people that are established and that are high society and that have an addiction and they need help.
In fact, the way 60 Minutes put it, they said, people like us are now using a drug other people used to use.
Mm-hmm.
Yeah. I agree with what Amanda said. It's all socioeconomic groups, all races, all ages. It's across the board. It can be your brother, it could be your mother, it could be your grandparents, it could be your kids, brothers, sisters. I mean, it's everyone.
You've seen it everywhere. Go ahead, Dr. Moore.
I definitely concur. Addiction has no boundaries anymore. One of the things I've noticed is that patients with higher socioeconomic status, it's more difficult to get them into treatment programs because the funding is all for the lower socioeconomic statuses, and so you're often battling insurance companies to get prior authorizations for medications. Mm-hmm. You can battle them for weeks, and they will come up with all kinds of excuses why they don't want to pay for this therapy. All the while, the person you're trying to help is it may be continuing to use. So that should also be another target.
Mm-hmm. All right. We go to Caroline, who's calling us from State College. Go ahead, please, Caroline.
Hey, Patty. It's Caroline.
Oh, hi, Caroline.
My question is, and you know my experience, how do we get these people that need help, like my son? He wasn't a heroin addict, but you know the whole story. 7 times in the hospital by Mike, calling the police, and he's not staying there. The doctor's releasing him. We need more help as parents, getting the people help that need help with the way the laws are and the human rights. There's not much we can do.
Good. Was there more to that, Caroline?
Huh?
I was going to ask Amanda to answer, but I didn't know if I cut you off.
Oh, no, that's okay.
Dr. Moore.
I think I can help answer that question. If someone can choose to make bad decisions, but we can't really hold them against their will unless they're very actively either suicidal or homicidal, and so that's really the problem. Someone can make bad decisions, which clearly that does happen.
You know, the difficult thing, I think, for parents is they might get them into a program, but, you know, federal studies show that for the best outcomes, you want a program that lasts at least 90 days. And so often they're 12-week programs or 2-week programs. And often it seems to me you're throwing your money down the drain. If you don't keep someone long enough, your chances of success are slim. What's your response to that, Amanda?
I think with Vivitrol specifically, they have to make a good decision once every 28 days. Do you know what I mean?
And that's to come to your clinic.
Well, yeah, to get the injection, even if it's not with PRS. Once every 28 days. It's not a daily decision as to whether you're going to use that day. Once every 28 days. I think that it provides that safety net for these patients.
And how long do you have to get that 28-day injection until you are considered, able to cope on your own without the use of medication? So
studies show it takes about a year for the brain to repair, to begin normally functioning again. Literature shows that they recommend a patient be on Vivitrol for 12 to 18 months. We go as far as to say 18 months for sure. We want to give the patient the best possible chance to have the recovery of the brain, to have all of those wraparound services in place, and to have changed people, places, and things, and all of those other things that come along with it.
Dr. Moore.
I want to ask Amanda a question, and this is for, I guess, for parents out there or others that may have someone that they want to, they feel that injectable naloxone or Vivitrol is a good therapy. What would they do to detox their loved one or themselves to be a candidate?
So what we do, you need to be abstinent at least 7 to 10 days to be appropriate for the medication. What we do in our clinic is we provide comfort meds by prescription for that 7 to 10 day period. So the patient comes into us as a consult. If they're still actively using, we can still help them. We would give them medications like clonidine, sometimes Neurontin, sometimes Trazodone, sometimes Zofran, to medicate the symptoms of withdrawal. Once they achieve that 7 to 10 day period of complete abstinence, we then do the naltrexone challenge test, which is a by-mouth form of naltrexone to make sure there isn't an allergy, and then we follow it up with the injection. So even if a patient's in active addiction, they're still appropriate for services with us.
And they can't come in and buffalo you, because you will do a urine test to determine whether they have, yes.
Every single appointment there'll be urine drug screen, and the medication itself is its own best truth serum. If they were to get the injection while they still had a dependency on board, they would go into what's called precipitated withdrawal, which is withdrawal on steroids. So it's withdrawal exemplified, and it's a lot worse. So a person is not going to willingly put themselves in that position when withdrawal is what the addict fears the most. So the medication, like I said, acts as a truth serum.
Yeah. Senator Yaw.
What both Dr. Moore and Amanda, and this caller hit the nail right on the head. And I could tell from the concern in her voice that she's had some personal experience. But it points out the fragmented nature of the treatment programs that we have. Amanda's program is great, but how do you get somebody in it? And what Dr. Moore is doing, he's very concerned about his patients and how he handles them, but how does his input get put in? What we found in all of our studies is our system is so fragmented, and we need somebody to put their arms around the problem, and that's where we came out with the community-based answer to it. We've developed a program in North Carolina called Project Lazarus that was started there.
With 7 spokes on a wheel.
And we've tried to started to duplicate that with a program in Lycoming County, which, and what we want to do is provide all the services and have somebody come in and be able to do the warm handoff, so that they just don't do the Vivitrol program and then all of a sudden where do they go? And we have everybody involved in it, from the district attorney, the president, judge. We've got doctors, the hospitals, colleges. We've got school superintendents.
The bottom line is there's a role to play for everyone.
Everybody, and your caller, her frustration. That's exactly what we need is somebody, one-stop shop to go to say, here's the next step, here's where you go, here's what you do.
You need that, and we're also looking at a state that some say, we're in the midst of a budget impasse that is the longest in 45 years. We've seen funding cuts in these health services, while at the same time this problem has quadrupled. So I'm sure a lot of Pennsylvanians are thinking, how can we possibly solve this problem when we've got other, perhaps even bigger problems? We can't pass the budget. How do you respond to that?
Education. I don't think a lot of people know. I really. The question was asked of me originally. How do you get the word out, bring it to a greater people's attention about this problem? And that's what we've tried to do. We've tried to do that by the reports, the hearings. Your program, it's great. If people don't know, there's never going to be any response to it.
All right.
And the first thing that people have to understand, too, in any community, especially community-wide, is we have a drug problem. There are a lot of communities in this state that they want to ignore it. Just sweep it under the table. We don't have a drug problem here. Because if you admit you have a drug problem in your community, it affects everybody. It affects your schools. Do people want to go there and live? Those types of things.
Dr. Moore, and then Jackson, I'm going to come to your phone call in just one moment.
There's actually financial information about the various treatment programs. So they've compared patients that receive in a methadone program and compared them to patients in a buprenorphine or Suboxone or Subutex, or patients in naltrexone or Vivitrol programs. And what the studies show is that, yes, the cost of the medication, the Vivitrol, is the most expensive compared to methadone and Suboxone, but all the other care associated with it is so much more reasonable. And so over 6 months, a Vivitrol program is much more economical. It's much
more cost effective.
Yeah, than putting someone in a methadone or Suboxone program. And we have oftentimes these patients are in these programs for 30 days where they're naturally detoxed and they're just released back into society, or from prisons and even the drug court systems. Yeah. They're just, we have this.
And their chances of success are very slim.
Yep.
When that's the way they're released. Okay, go ahead, Amanda.
There's a really exciting thing happening in Blair Armstrong in Indiana, and they've started a jail reentry program, meaning that they are starting the patient on Vivitrol prior to release from being incarcerated. So, and then they're referred out to us. The same thing happens with a patient in inpatient rehab. They get their first injection in rehab, and then they're referred out to us. So instead of, it lessens the bleed on the taxpayers. They're not coming out and then reoffending or having a positive urine drug screen and ending up back in the system. If you can get them started on the medication while they're incarcerated, they come out, they follow up with us, they have a provider, and they can then work on becoming that functioning member of society again.
And that's what they're seeing with drug courts, where therapy is part of the program. Yes. There's a 25% recidivism rate versus the general prison population, where there's a 75% or higher recidivism rate. So it sounds like it does make economic sense. As promised, Jackson from New Bloomfield, you are on the air. What's your question, please?
My question is for Nurse Amanda. How effective would this drug be that her company uses in stopping my cravings?
So naltrexone takes away cravings completely. That's what probably about 99% of our patient population tells us. They report zero cravings to abuse opiates or alcohol. It's the way that it works in the brain. So if you're somebody that's struggling with addiction, if you were to be on the Vivitrol, I would say that you wouldn't have cravings at all. That's what our patients report to us.
Now, what do you say to people, Dr. Moore and Amanda, to those who say we're replacing one addictive substance with another? I'll begin with you, Dr. Moore. When we talk about methadone and Suboxone and those sorts of things, you've heard that argument.
Oh, sure. And when I hear it quite frequently, and I always explain it for a patient with methadone or Suboxone. It's really a risk-benefit analysis. Do you want someone receiving a drug that's manufactured by a pharmaceutical company that's highly regulated, you know exactly what it is, or do you want someone continuing to use a drug that you don't know who's had their hands on it, what it's been cut with?
And we know that heroin, bad heroin that has been cut with something, is the reason for a number of deaths in Pennsylvania.
Exactly.
You had something to add, Amanda?
We believe that there is a medication that's appropriate for every patient population. If you're going to look at, we have a taper program that involves Suboxone that with the goal for them to eventually be completely abstinent on Vivitrol. Obviously, Vivitrol supports the complete abstinence. But if you're looking at even the change in lifestyle from somebody who's in active addiction to somebody who's on Suboxone, they're not stealing, they're not robbing, they're not vandalizing, they're not doing all of those things to get the next one in. They're on a prescribed medication. So there are certainly, there's issues with diversion with Suboxone. There's a lot of stigma attached to it because it has been misused. But used in the appropriate way, it's a good medication to bridge somebody to complete abstinence.
I'm going to go to a call, but I want to get back to this idea of stigma. So remind me of that. Jane from Somerset, you are on the air.
I'm asking about a patient with actual chronic pain that's severe, but also is addicted to opioids. What do you do for someone like that?
Dr. Moore, that's a tough one.
When you're treating that type of patient, you can't treat one without the other. So if you're going to treat pain, you also have to treat addiction. You can't isolate one, and so that's really the key to therapy. A lot of times those patients have problems getting into pain clinics once there's been a history of abuse of medications or street drugs, and it definitely what to do, it's definitely a challenge.
But doing the same thing, someone who's in chronic pain, they're addicted to opioids and they're still in chronic pain. If you're doing the same thing and you're getting the same results, it sounds to me like it's time to change. And what do you think, Dr. Moore, of something like trying acupuncture or, as I said earlier, exercise and combining these things with the other treatments?
I think anything that works. Chronic pain is just like addiction. It requires a unique approach, patient-centered. So whatever this patient may be different from that patient, and if acupuncture works for one patient, that's great. Continue it.
All right, we go to. I hope I pronounced your name correctly. Chink from Erie.
Thank you.
Hi. What's your question or comment, please?
Yes. Good evening to everybody on the. Yes, good evening to everybody.
Good evening. What's your...
I wanted to ask, do y'all feel as though that it's a crime against humanity when these pharmaceutical companies is getting these drugs FDA approved and not knowing the long-term side effects? Or does anybody even care? Or is they getting paid to approve these drugs, not caring, and then this is how these people get...
I think what he's getting to is something that I said earlier. Between 2009 and 2012, Vicodin was the #1 prescribed drug in America. And so I can understand where some people are saying the pharmaceutical company has some responsibility here. What do you say to that, Amanda?
I think that if you're considering what these medications were made for, I mean, we absolutely have become a society of what's your problem, here's a pill. Absolutely, and it's across the board for everything that there is. But certain medications were made for patients who experience horrific pain. I mean, cancer patients, people that need that medication in order to function at all. So I don't know that I would find it I would hope in my heart that a company wouldn't create a medication with the intention of creating an epidemic, right? But I think that, again, it goes back to there is a certain population that's going to be appropriate for a certain medication. And I think that, you know...
Well, that brings me to this, Dr. Marmio. I only have a couple of minutes remaining, but only about 25% of those people who try heroin will become addicted. Not everyone. Am I getting that right? So why does one person become addicted and another person doesn't? Do we know enough about that?
Has to do with genetics, probably who you surround yourself with. One of the common things I've heard patients say is people, places, and things. Just it depends on what's going on around you. There's actually some studies on in kids who have been naive, so not on any drugs before, and it doesn't take very long to get someone hooked or dependent on these drugs, and in as little as 9 days, 100% of in the study I'm thinking of were dependent on opioids in the ICUs.
Mm-hmm. We have just a couple of seconds remaining, and I'm going to end with you, Senator Yaw. On a legislative point of view, what's out there that gives you encouragement as we go forward and try to tackle this epidemic? Well,
I think, as I said at the beginning, we need to learn about the problem. We've already addressed some of the things like the Good Samaritan bill, the naloxone, the drug registry. We've tried to do that. We need to learn about it. We're probably going to introduce some legislation involving drug education for doctors, maybe in medical schools. We need some better reporting requirements from coroners as to where we are. We're at the beginning of this, and I think that, like I said before, programs like this raises the awareness. All right, and on that note, unfortunately, we are out of time. Thank you all so much for being with us. Our guest tonight, Senator Gene Yaw, the state senator for from Pennsylvania's 23rd District, Dr. Philip Moore, an internist with Associates in Medical Toxicology, and Amanda Cope, a registered nurse and the administrative director of Positive Recovery Solutions. I'm Patty Satalia. For all of us here at WPSU, thanks for joining us, and good night.